Alrighty, I think we'll go ahead and get started today. Good afternoon, everybody. Welcome to our Cancer Potpourri Echo series. This is going to be kind of a short series, just 2 parts with Dr. Crapko today, and then Susan Howe next month. Kind of wanted to bring together some different topics related to cancer. So Dr. Crapko is going to be talking about the TAMIS procedure for us here today. And then next month, Susan's going to be speaking about radon testing and mitigation. So if you're not familiar with Project Echo, we are a telehealth program based at the University of Nevada, Reno School of Medicine. And what we do is we bring together different subject matter experts and content and speakers for you. We provide continuing medical education, and really it's just a great platform for connecting all the wonderful resources that we have throughout the state. We'll start off today's session. We'll go around, we'll do introductions. We'll have our speaker and staff for the day introduce themselves. Then we'll go on to all of you and have you introduce yourselves for us. Then we'll get going. Dr. Crapko will pull up his slides and we'll go through his presentation. And then at the end, we'll have some time for Q&A. So again, my name is Troy Jorgensen, Program Manager for Project Echo Nevada. All right, Dr. Crapko, if you could introduce yourself for us, please.
Oh, hi, this is Matthew Crapko. I'm a colon and rectal surgeon. I work with Western Surgical Group in Reno, Nevada. So as part of the GI quality committee at Renown Hospital, we decided to reach out to Project Echo as possibly a way to do some educational opportunities. So I'm giving it a shot here today. Please feel free to give some honest feedback at the end. This is the first time I've tried this with Project Echo, and we'll see how it goes and whether it's useful or not.
All righty, thank you. Sneha?
Hi, everybody. My name is Sneha Sharma, and I'm the program coordinator for Project Echo Nevada.
All right, thanks, Sneha. And then Kat, I see you're joining us as well. Kat, looks like you're off mute, but maybe we don't have audio for you there. All right, Kat, sorry about that. All right, so now on to everyone joining us here today. Cassie, you're first on my screen. If you could introduce yourself, please.
Hi, I'm Cassie Goodman. I'm the Cancer Early Detection Programs Manager and a Patient Navigator at Nevada Cancer Coalition.
Thanks, Cassie. Hayes?
Hi, Hayes Wilson. I'm a primary care PA based out of a rural health clinic in Douglas County, Nevada.
Thanks, Hayes. Glad to have you joining us today. Laura?
Hi, Laura Pinto. I'm a healthcare administrator as well as a registered nurse.
Thanks, Laura. Glad to see you today.
Thank you.
Craig? Craig, looks like you're still on mute there. There you go. Go ahead.
Yeah, hi, I'm Craig Sandy. I'm a gastroenterologist and also with Renown, there's GI and Liver Center of Excellence.
Thanks, Craig. Glad to have you joining us today. Ashley?
Yeah, I'm Ashley. I'm just a PA student, part of the AHEC Scholars Program.
Thanks, Ashley. Glad to have you. Kathy?
Hey everyone, I'm Kathy Zoller. I'm with the American Cancer Society, and I work with cancer programs in Northern Nevada and some other FQHCs around Northern Nevada too.
Thanks, Kathy. Glad to have you. It's just a number. It's 17434 is the screen name. If you could unmute yourself and introduce yourself for us, please. All right, looks like you're off mute, but we're not able to hear you. So if you just want to write in through the chat box with your information, that would be appreciated. Thank you. Ron Wright is next. Ron, do we have audio for you here today?
Hello, good afternoon. Sorry for the echo.
Ron, looks like we're having some feedback. You might have another device that you're logged in on.
Yeah, there's two other people next to me. We're watching.
All right. Well, thanks for joining us today. Kay Harris.
Hi, I'm Karen. I'm next to Ron.
All right, Karen. Glad to have
Work
you.
in behavioral health, Henrietta Johnson Medical Center, Wilmington, Delaware.
Wonderful. Glad to have you today. Onesimus Al-Amin. I think you wrote in already from
Yes.
where? Henrietta Johnson Medical Center.
Yes, I'm a social worker graduate student at Delaware State University, as well as a case manager at Henrietta Johnson Medical Center.
Excellent. Glad to have you today. Thank you. Jessica Thompson is next. Jessica, please go ahead.
Hi, I'm Jessica Thompson. I'm a registered nurse with Renown.
All right, Jessica, glad to have you joining us here today. Dr. Koss.
Michael Koss here, radiation oncologist, Reno, Nevada.
Glad to see you, Dr. Koss. Thanks for joining us as always. And Dr. Bayan.
I'm David Bian. I'm just another doctor, Ely, Nevada.
Thanks, Dr. Bayan. Glad to have you as always. All right, looks like there were some other folks trying to join us. Hopefully they're able to get back in with us here today. So I'll turn it over to Dr. Crapko to start his presentation. Throughout this, please feel free to chime in, unmute yourselves, or write into the chat box if you have any questions or comments that you'd like to share.
All right. Can everybody see the presentation now?
Yep, perfect.
Okay, good, because it's got video, so it won't be very interesting without it. So,
okay.
Hi, I'm Dr. Crapko. I do mostly colon rectal surgery, but general surgery too, and in Reno, Nevada. And I'm here today. We wanted to talk about a technique called TAMIS, which is a acronym for transanal minimally invasive surgery. And basically to kind of use that as a springboard to talk about some of what we're doing in treating neoplasms, benign and malignant of the rectum lately. So we'll start with a patient, initials TC. It's a 74-year-old male who underwent a screening colonoscopy and had multiple polyps removed. But he had, as part of this, findings of a sessile polyp in the rectum. It's about 2.5 centimeters diameter, 8 centimeters from the anal verge, covering about a quarter circumference of the rectal wall. And biopsies were taken of this sessile polyp, and it came back as a tubulobilous adenoma with some high-grade dysplasia. Now, this gentleman has the usual comorbidities we all know and are familiar with in a 74-year-old. And so you're dealing with a not necessarily malignant, but potentially malignant lesion in the rectum. And so this raises questions of, okay, what do we do about this? What's the risk of cancer? How bad is this surgery going to be? What are my options? And we'll kind of go through that as part of the case. So we'll talk briefly about rectal neoplasms, and I'll come back to some of this information in more detail later as well. The upper right-hand corner, you've all seen and loved this image since school. Basically, it's showing the progression of benign lesions or polyps to malignancies and metastasis, that these lesions start locally, that they grow and spread through the layers of the colon and eventually spread to lymph nodes and to distant sites. In the lower right-hand corner, you can see this was a pretty good sketch of the normal layers of the colon wall. And basically, how deep a lesion goes through these layers is going to be the determinant of how bad the tumor is, or the tumor staging. It becomes malignant once it gets to the submucosa, and then the staging increases once it hits the muscularis propria, once it gets through it to the fat, and then once it spreads to other organs. So again, reviewing our oncology, that's all determining T stage, or the stage of the tumor itself. And we know that because of this progression, that even benign lesions have to be addressed. We don't want to just leave them to grow into a cancer. The problem, though, is you can see in this lower image, the rectum is a surgically difficult area to access. You know, we don't need to go through every detail of anatomy, but suffice it to say, the rectum's kind of packed in, ringed by bony tissues, ringed by fascial planes, pushed up against the sex organs, the bladder, the spine, nerves, etc. So when we're talking about operating on the rectum, it's a challenging area to reach surgically. Far better for these lesions if we could go through the anal canal, which is a natural orifice into the rectum. And that would be a less morbid procedure. Now, we know that compared to traditional proctectomy or removal of part of the rectum, transanal approaches are far less morbid. You know, the complication rates are listed around 10%, but even that 10%, you know, it depends on how people qualify complications. You know, does postoperative bleeding count as a complication? Well, it's yes, if you're having it, but it can also qualify as a normal finding after having any surgery on this part of the body. So complication rates are low, mortality is very low. So we'd like to do sort of a natural orifice approach when we can. But, and this is the question we're going to come back to over and over again, when can this be done safely? There's two big problems with neoplasms that we have to address. Number one is knowing what you're dealing with, and that means cancer identification. Some lesions, you do a scope, and you know, Dr. Sandy and Shay, who I see logged in, can tell you, you just look at them and you know, okay, this is going to be a cancer. We just have to prove it and go from there. But even with benign appearing lesions, or more often questionable lesions, you can't always know for sure. Biopsies by nature only take a small sample of a lesion. And we know that tubulovillous adenomas, which is what this gentleman has, have been reported to harbor a malignancy up to 20 to 25% of the time. So even if our pre-procedure pathology is benign, we know that we could potentially be dealing with a malignancy, and we always kind of have to act accordingly. Staging early cancers can be very imprecise. Even with imaging, it's not always possible to tell for certainty what we're looking at. So that's the first big problem. The second big problem is local recurrence. Obviously, if we're going to take something out, we want to do it once. We don't want it to grow back. The first attempt at removal is the easiest and most likely to be successful. After any attempt at removing a lesion, the body's going to try to heal that area, and it's going to form a lot of scar tissue. And what that tends to do is it pulls things down and sort of tightens up all the tissues, and it's going to make any subsequent attempts at removal a lot more technically challenging. Even worse is the fact that when we're coming to cancer, recurrent pelvic cancers, i.e. a cancer that grows back after initial presentation, carries a worse prognosis than the first time around. Pelvic recurrences are a big problem, and they're not easy to treat, and it gets far worse. So whatever we do, we want to do it once. And then the other issue with local recurrence is that local excisions don't address the possibility of nodal disease. And we know that the higher the stage of the tumor and the higher the stage of the cancer, the higher the recurrence rates. So cancer identification and local recurrence, kind of the two big issues we'll get back to a lot with these sort of talks. So what were the traditional ways of getting a lesion like this out? Well, one would be endoscopy. Advances in mucosal and submucosal resection have actually made this a fairly attractive option. You have the rectum insufflated, you can visualize it with an endoscope, and the visualization is pretty good. The big limitation and problem with endoscopy is removing an intact specimen. You're operating through a very small hole because it's a scope. And so that channel doesn't give you a lot of wiggle room or the ability to articulate as well as you'd sometimes like to. And so taking out these specimens intact, and we're going to go back later and review again why that's so important, gets very technically challenging with a scope technique. And again, multiple attempts at removal are going to just increase the difficulty each time we do it. However, comparing that to the traditional surgical approach, which in the lower right-hand corner is just looking up somebody's anal canal with a retractor, we know that doing we'll call it an open transanal surgery for lack of a better term, or traditional, we know that the local recurrence rates of lesions and the chances of getting an end block or intact resection are better with the surgical approach. And, you know, this is because you have two hands, you can get multiple instruments in there. The problem is traditional techniques only access low and small lesions due to visualization issues. Whatever you're looking at surgically with traditional techniques, you had to look through a narrow channel, or it had to be low enough that you could see it. Historically, this was kind of limited to things lower than 8 centimeters from the anal verge and, you know, less than half of the circumference. But I can tell you anecdotally that with the rise in obesity, these traditional transanal resection techniques are actually getting harder to do than they may traditionally even have been. I mean, a gentleman like our patient who, you know, has morbid obesity, you may not even be able to see 7-8 centimeters because this guy's body habitus is going to be such, you're not going to be able to access that high into the rectum. So these are our two options, neither great or perfect. So that's where this technique TAMIS comes in. Basically, you can see here, it's the easiest way to conceive of this is laparoscopy for the inside of the rectum. This works the way that like a lap chole or lap epi would work, more or less. You have a plastic disposable port that you put in through the anal canal, and then there's this gel cap on the outside, which provides your working ports. And what that allows you to do is insufflate the inside of the rectum, so you have a workspace. You can then put a camera and a couple instruments in, and you can manipulate lesions and remove them and see what you're doing. So this kind of bridges the gap between those techniques in that you can get higher up into the rectum, but because of the ability to have multiple hands and instruments, this enhances your ability to remove lesions intact, close defects, etc. And the costs of this are not unreasonable because besides this disposable access port type, and there are a couple manufacturers that make them, the instruments you're using and the cameras are all standard laparoscopic equipment. So this isn't something that's hard to obtain or that specialized beyond the scope of this talk, but the original work on these sort of transanal minimally invasive techniques was called TEM, and you may see that in different parts of the country. That's sort of a microsurgery scope type approach, which again, I don't want to go too far into the weeds on different techniques, but basically the disadvantages of that are that it's a lot of specialized equipment and it represented a very big investment for hospitals or institutions to have that available.
Dr. Crapko, just for a quick second here.
So we'll
Dr. Crapko, your audio is kind of coming in and out. So if we can make an adjustment here, if you go down onto the Zoom toolbar next to the mute icon, do you see that?
Okay, yeah.
And there's a little, like a little caret, like a little up arrow. If you click on that, there'll be a button that says audio settings.
All right.
So click on audio settings and it'll open up a thing. It says speaker and then microphone. And then in the microphone section, there's a checkbox that says automatically adjust volume. Is that checked right now?
It is, yes.
Okay, so uncheck that and then move that slider at the top there all the way to the right.
All right, is that better there?
That's a lot better, yeah.
Okay, thank you so much. Appreciate the technical help.
Okay.
All right, so moving on, we're going to show a video of the TAMIS procedure for this particular patient and hopefully kind of better illustrate what we're talking about. All right, so I edited the OR procedure down so we don't have to sit here and spend the next hour watching me fumble and clean the camera 30 times. So we're just going to see some highlights of the procedure here, which hopefully will make me look better than normal. So this is the lesion you can see right here on the left. That's the sessile adenoma, tubulovilous adenoma. And so now you can see this is the start of the procedure. We're measuring out about 1 centimeter from the lesion. And what we're doing is we're making a full thickness incision through the wall of the rectum. I'm using a harmonic scalpel. So you can see here, the third port is obviously the camera, which you're looking through. And then you can see sort of my left and right hand allowing me to work. Now, it's certainly not as smooth as an open surgery would be. You're still kind of chopsticking a little bit with this technique. But with a little patience and persistence, you can see that you can articulate your instruments around, and you can do a fairly decent job of making sure you get clear margins on these lesions as you remove them. All right, moving forward a little bit, I've worked for a while, cleaned the camera, swore a little bit. Now here we are moving onwards. So now you can see as we're removing this lesion, one of the virtues of this approach, you can see this yellow fat showing up here. That tells you that you are truly going full thickness through the wall of the rectum with this resection. So we know that we're getting all of those layers, mucosa, submucosa, muscularis. You're getting all those layers, and you're keeping the architecture of the lesion intact in doing this. And you're making sure that you're getting completely around it. So there's if you're careful with this and you watch your lateral margins, there's very low risk that you're going to be leaving pieces of tumor in there. A little more time passes through the magic of editing. So you can see I've worked completely around it, completely under it, and now I'm kind of working up here into the proximal rectum. That's a sponge that we put in proximally just to kind of hold the workspace open. And so now you can see we've just finished dividing the normal rectal tissue above the lesion. And then now as I take these last couple bites on the fat, it's going to be very important. You'll watch and see that my left hand is going to kind of lock into position and not move. And that is going to allow us to orient the specimen so that I know what's proximal, what's distal, what's, up and down, so that if we do end up with a positive margin or we don't get it all, it can give us some clue as to where to go next or, where our errors were. So I think one more bite should do it here. And there we go. I think that's satisfying to watch, but I do this for a living. So. All right, so then the specimen's removed. And so then you can see here, we're taking it out. This is a good shot here. I can kind of scroll through the video a little bit. You can see patients in lithotomy position. The anus is accessed with this port. And then we use camera up here, right hand, left hand, and then we can get in there and access these lesions. And so it's a fairly decent system to use. This extra hose here is helping with insufflation so that we can do that. And then there comes our lesion pulled out. Then this clip, what we do is we take these lesions and we tag them out on a sponge or towel, and then I'll just write with a pen proximal, distal, and then that helps the pathologist kind of orient, and they will take this downstairs and take a look at it. You can see that the edges do shrivel a fair bit more than you'd like, just because of the energy devices we use, but they're still able at the microscopic level to take a good look and make sure that those margins are clear for us. Having removed the lesion, the next thing we'll do is try and close the defect. There are plenty of reports in the literature. You don't technically need to close these defects. They can be left open, and believe it or not, this will heal in and granulate with time. However, there's going to be, in my experience, increased discomfort and bleeding and urgency as a big wound like that heals. So I think that if you can close this up, you're doing the patient a favor. So what we're doing is now we're doing some suturing with a barbed suture to make it a little easier to tie the knots. And I'm going to kind of run a stitch between the proximal end here and the distal end here to kind of recreate the normal rectal lumen. Again, through the magic of editing, we've worked our way around. And so now we're down to the last few bites. One of the limits of this particular technique, as you can see, is that you can only, when things get a little too distal, you start to run into the plastic edge of the actual access device. But still, you can go through, you can zip all that shut, and you can kind of restore a normal lumen for them so that this function should be pretty good. And so finally, we just check, we make sure that the lumen's widely patent. We didn't sew anything shut that shouldn't be. And the sponge actually does kind of aid us with that at the very end. Last thing I do, pull that out proximal. I know that the rectum's patent, and we know that the lesion's been removed. So what results did we get from all that? The pathology predictably said we had a 2.6 centimeter tubulobillous adenoma. It did have high-grade dysplasia in it, but no malignancy in this case. So this would have been one of these 75% that didn't have a malignancy. And it was removed with clear margins, so they didn't see any sign of residual adenoma. Patient experienced some postoperative urgency and some minor bleeding with bowel movements, which is really not unexpected from something like this, but he didn't require any intervention. And worth noting that with a procedure like this, patients can go home the day of surgery. They have surprisingly little pain from this because you're operating up in the rectum proper. So there's really not any nerve fibers where we did any of that dissection. So, you know, besides the dilation of the anus and the access port, there's surprisingly little discomfort from this at all. 6 months later, the patient has not had any recurrence of the adenoma since the procedure. So we'll talk about applications of this technique. First, for benign disease. What that does is it allows for en bloc resection of a rectal lesion with clear margins. Now, I've looked at some of the long-term follow-up data for these resections, and the data is still suboptimal, is the way it's described. The problem is this technique, if you think about it, it applies to lesions of the rectum that are not a big enough cancer that we had to do a big surgery, but also big enough that it wasn't just a simple matter of grabbing them with a biopsy forceps. So it's kind of limited in scope. And so I think that a lot of the data that has been published on this technique, they tend to get a decent number of patients, pool together a lot of benign and malignant cases. With time, I think that, you know, with any technique, data gets more robust. But again, it allows for an intact pathology specimen. Here's the big question then. Okay, we know we can remove benign polyps, but can this be applied for true rectal cancer? Well, the gold standard treatment for rectal cancer still remains doing a proctectomy or a low anterior resection. Basically, you're going in, you're dissecting in fascial anatomic planes, you're taking lymph nodes and fat around the rectum or relevant part of the colon, and you're getting wide margins around the tumor. This is a effective technique, and when applied, it works well. And you know, local recurrence rates are less than 5% with a clear surgical resection. So the gold standard is there for a reason. However, this remains a major surgery. You know, this is not this is certainly not a small outpatient procedure to have a proctectomy done. And there's long-term implications, even when this goes well, for bowel function, sexual function, and oftentimes a need for temporary or even permanent ostomy placement, depending on the circumstances. So, you know, any transanal procedure for cancer does need to compare favorably as far as oncologic outcomes go. You know, obviously we all want to have a simple procedure and go home the same day, but that's not worth very much if you don't survive your cancer. So I think that helps frame the discussion of which cancers we can use this for and how aggressive we can actually be. The other big point I want to make is that when we do a proctectomy or a formal resection for cancer, we're removing, this slide doesn't show it great, but we're removing a large amount of fat and nodes around the actual bowel. And that's giving us very valuable information about lymph node staging and cancer staging based on that. And so when we're doing a transanal procedure with any technique, you're not getting that lymph node data. You're only getting the actual lesion itself. And so that's going to weigh into our outcomes as well. Looking at some colon and rectal cancer staging, and then I repeated this little picture here for an illustration. The T staging, as we know, is all about the tumor depth. It starts up here. It grows through into the submucosa, which is a T1 in the definition of cancer. T2 goes into the muscularis propria. 3 goes through the muscularis, kind of into that fat, and then 4 would either be in the peritoneal surface or invading another organ. Sadly, in the case of the pelvis, T4 disease is usually, there's not going to be any gap over here. This is going to be right into the bladder, prostate, vagina, etc. Nodal staging for rectal cancers has to do with how many nodes we have. Now, the reason I put all this up, and we're trying to stay focused on more of a technique to keep this talk in a reasonable amount of time, but you can see here on the right that 5-year survivals predictably decrease as the stage of the cancer increases. And so you can go from a stage 1 cancer with a really good 5-year survival, and then it's going to decrease down to a stage 4, which is not very good at all. And so knowing where you are on this spectrum and having accurate information about this, it does matter. And, you know, beyond the scope of this talk, but it's this sort of information that we're using to determine who's getting chemotherapy, who's getting radiation, etc. So it would be nice to know the nodal status, but we're going to ask the question now, and this has been studied and it's promising, can we guess this nodal status based on the tumor status, i.e., pretend we don't know this box right here at all, pretend we only have the information up here, can we make some educated guesses as to how far this cancer has progressed into here? One way to do it would be imaging. With most rectal cancer patients, we will image the pararectal fat or nodal tissues using either an MRI or an endoscopic ultrasound. But those are variable in accuracy. Studies report anywhere from 63 to 85%, so it's not perfect. It's helpful, but our best information about nodal status is still, and there's no substitute for this, having a pathologist take the nodes out of a specimen and look at them under a microscope. But you don't get that data unless you've done a proctectomy already. So what we are left with are educated guesses most of the time. Fortunately, this has been well studied, and we found that there is a correlation with tumor stage and nodal status. If we have a T1 tumor, the risks of nodes being involved is 10 to 15%. Now, I don't want to confuse the issue too much. I'm not saying that a T1 N1 tumor isn't stage 1 cancer, that's stage 3. What we're really talking about in this context is, as I put it, hidden stage 3 disease, i.e., we know there's a tumor. Are there nodes involved, and how likely is it to be stage 3 that we just can't see? If it's a T1 tumor, that likelihood is actually low. It's only 10 to 15%. But once you jump up even to a T2 tumor, the likelihood of nodes being involved in this actually being stage 3 goes up to 20 to 26%. And that is broken down even further by the important study done by Kikuchi, which they did some data on looking at upper, middle, and lower thirds of the submucosa for polyps. And so if you can see over here on the right, I mean, we're really splitting hairs now. We're talking about, this is the mucosa, this is the muscularis, and you're talking about measuring thirds of a microscopic invasion. But it matters. Kikuchi class 1, which is the upper third, only has a lymph node involvement rate of 1 to 3%, very low. But once you get up to Kikuchi 3, i.e. it gets down to here, the percentage jumps up to 23%, which is really almost the same as a T2 tumor, which makes sense because any tumor involving this layer is T2, that we're talking about a couple cells at this point. So I think that it's interesting that you can see that progression, but what this really highlights is, again, and I keep persevering on this point, sorry, is the importance of architecture when looking at these tumors to stage them. You know, you're not going to know upper versus lower third unless you have an intact specimen for the pathologist to look at. Moving on. So what are the results? And this has been used for rectal cancers. For T1 lesions, there was a study that showed 59 patients having local excisions. The 6-year disease-free survival was actually 83%, which is not bad. If we went back a couple slides, that's starting to approximate what we're getting out of a proctectomy. So it's not, that's not terrible. But in that study, and this again is the limitation, a third of the patients initially enrolled actually had to be excluded because of positive margins. Now, this study was important, but it wasn't using, it used a lot of the older open techniques. But I think that what that shows is that margins are important, and any technique we can use to get clear margins is going to be beneficial. There's been some single institutional studies as well, and these show cancer-specific survival ranging from 89 to 92% for T1 lesions. So when done correctly for true T1 and 0 stage 1 cancer, the survival is as good as a proctectomy. That's great news, because the morbidity of this procedure versus a proctectomy is vastly different in terms of patient recovery and consequences. There was a meta-analysis done of T1 cancers treated with local excision, and they concerningly showed a lower 5-year survival in the local excision versus the traditional treatment group. But what was interesting about that meta-analysis is they broke down these local excision groups into the open, or just using an anal retractor looking at it directly, versus the minimally invasive. The minimally invasive subgroup did not show this problem with lower survival. So again, it demonstrates the virtues of visualization. If you can see what you're doing, those margins are a lot easier to get. Local recurrence was higher for transanal excision than it was for proctectomy, which it probably always is going to be to some extent, but mortality, complications, and need for permanent ostomy were always significantly lower. So the conclusion was there's a clear role for excision in T1 and 0 cancer. The risk benefits definitely support this approach. But, and this is always the big but that we keep getting back to, how do we know for sure that's what we're treating? We want to make sure that this isn't involving nodes. And unfortunately, that is always going to be a risk with this approach, and you just have to counsel patients and say, listen, it's a T1 lesion. We don't see any nodal disease. Your risk is 10 to 15%. The nice thing about this is if you're resecting T1 disease, you can do Kikuchi staging on it, and you can maybe give them even better numbers post-op than you can beforehand. What if we want to get more aggressive, this like T2 lesions? Well, the problem here is the risk of nodal disease has gone so high. Now we're up to 20 to 25%. You're talking about missing nodes in up to a quarter of your patients. That gets a little cavalier, especially when we have a proctectomy that can be completed safely. I don't want to dig on the LAR too much. It works. So for nodal disease, proctectomy or aggressive surgery remains the procedure of choice, even for a stage 1 cancer with a T2 primary. However, there's work being done. The same study looked at T2 rectal cancers, and they tried doing local excision plus post-op chemoradiation. And they were able to come up with a 6-year disease-free survival of 71%. Now, that's low for stage 1 cancer. That's where stage 2 or 3 cancer tends to lie overall. There was another trial that tried neoadjuvant chemoradiation therapy followed by local excision. And in that trial, the disease-free survival was 87%, which is jumping back up to that 89% number that you're aiming for a stage 1 cancer. So, however, if you're treating stage 1 cancer with surgery alone, you're not needing chemoradiation, but it raises intriguing possibilities. As chemoradiation gets better, as techniques surgically get better, we may see in the future an expanded role for sparing patients aggressive surgery and doing more with these transanal techniques. So I think that the way to break this down and explain it to patients is there's been a talk of calling it a radical biopsy, basically saying, all right, you have a patient with a benign or what we think is a T1 lesion, and we say, listen, we're going to do what's called a radical biopsy. We're going to go in, we're going to take the whole lesion out, we'll get some data, confirm whether it's T1 or not, and then we can decide based on the results what to do next. Is that safe to do? Well, the answers turned out to be yes. There was a study where they looked exactly at the question of 63 patients undergoing local excision who then had to have a proctectomy down the road. Now, these had a variety of T-stage disease, but basically they did a local excision, they found a cancer, patient wanted everything done, so they go and do a proctectomy. The big question was, does the proctectomy still work after you do this? And the answer was yes, that 84% of the time they could do a restorative procedure, i.e. they did an anastomosis. And of those 63 patients, none of the T1 or T2 disease patients had a local recurrence in this particular study. In other words, proctectomy was safe and it was effective even after a transanal procedure. So that's good news for these early stage lesions, that you still have a backup. Patients with a more advanced T2 or even T3 cancers, now they have been treated with this technique, but at that point, you're getting away from what we would say is best treatment, best therapy. But now we're getting into the realm of a lot of patients don't necessarily want best treatment or best therapy. You can have patients who just refuse radiation, who can't handle chemo, who can't get through a major pelvic surgery. And so it's good to have this technique in your back pocket and saying, well, the results may not be as good, but they're certainly better than doing nothing. So it's a nice tool to kind of have in the arsenal when we're teasing out these various presentations of rectal cancers. But again, it's very important to have preoperative counseling regarding the risks of recurrent disease or as we said, missed nodes for any of these type of lesions. So just to kind of illustrate how this plays out, I made up 2 fictional patients, but these are very real examples, honestly. Patient A, 40-year-old female, otherwise healthy, young children, young, healthy, T1 rectal tumor, so stage 1 cancer. You talk about a transanal procedure. Well, yeah, it's less invasive, but a patient like this is thinking in terms of decades of survival. And they're saying a 10 to 15% chance you're going to miss a lymph node. That sounds risky to me. I'm young. I want to survive a long time. I think I want the safe, tried and true, let's remove the whole rectum and make sure we got it all approach. And that's not wrong. But that's often a decision. But contrast that with patient B, 85-year-old male, multiple comorbidities, risky with surgery. This guy is a gentleman who already struggles with continence or bowel control, and he has a T2 tumor. Well, it's all your perspective, right? An 85-year-old guy with this profile may say, well, there's only a 25% chance of missing some of it, but this is a day surgery and I don't have to have an ostomy and I don't have to stay in a hospital and I might not, I don't have to take that risk of a nursing home. There may be some elderly patients who say, hey, I'll take those odds. That sounds pretty good to me. So even though this patient is higher risk for a TAMIS procedure, they may be more likely to take it than the lower risk patient. So I think the conclusion with rectal cancer, any talk on this always is going to be multidisciplinary tumor conferences. There's so many options and so many modalities we have for these lesions that the number one way to treat this is with a multidisciplinary team where we can sit down, we can individualize every case, and we can figure out what's going to work for which patient. So in conclusion, TAMIS is a safe, effective way to treat benign rectal lesions. These techniques also play a role in rectal cancer, but decisions are complex and every situation is unique. And there are ever-expanding options and considerations. So I think the take-home message I always say with cancer is make sure people get screened. The earlier we find lesions, the more options that are going to be available. And I think for those of you who do primary care, this is valuable info to take back into your practice so that when patients are giving you pushback of, oh, well, they find a cancer, I'm just going to get an ostomy, or I'm just going to have a big surgery, you say, hang on, there's a lot out there. Let's get the information and get you treated. So that's my talk. I'll open it up for questions, and we'll go from there. Thank you.
Great information for us today, Dr. Crapko. Thank you so much. All right, so yeah, we'll open it up to the group right now for questions. Please feel free to unmute yourselves or write in through the Zoom chat box. Dr. Sandy?
Yes, I'm trying to unmute. Thank you for the talk, Dr. Crapko. My question would be, what would you advise to endoscopists who discover a polyp in the rectum that has it's very suspicious for malignancy? You can't really tell. It's not a clear-cut cancer. There's always that issue. Do they go ahead and do snare polypectomy, sometimes piecemeal, or do they leave it alone? And we've had a few patients like that. And, when cancer is found, you really have a lot more difficulty understanding the stage, because you can't tell whether it's T1, T2, et cetera, without full thickness. So what would you advise gastroenterologists, let's say, that are doing colonoscopies? When should they consider backing off, maybe taking some biopsies and then letting you have a crack at it?
Well, I think that, it's exactly, you made the point right there, is a piecemeal resection is never a good idea in the rectum. So I would say, my advice would be, you're never wrong to just do a simple biopsy and find out what it is and refer to surgery so we can take a look at it and remove it transanally. That's never wrong. Obviously, we don't want to send every little thing. So I would say, if you're 100% certain that you can get it out with the architecture intact, i.e. that you're not going to disrupt any part of that lesion, then okay, go ahead and take it out. And there are going to be some pedunculated small things that you're like, okay, this is easy, I'm 100% going to get all of it, great. But I think if you're not sure you're getting it all in one shot, then I think it's better off removed surgically at this point.
Thanks for your question. Other questions from the group? Dr. Koss?
Yeah, thank you for that presentation, Matt. That was very good. I learned something today. I learned quite a bit. It seems to me as though the evaluation to determine whether there is nodal positivity when you don't know is critical. So when I was much younger, we had something called the Papillon technique, where we treated patients with radiation therapy through a transanal technique. And we looked at grade, size, and morphology. These days we have a few more factors to look at. Do you guys have nomograms where you look at gene analysis, family history, patient age, anything like that?
I think that there's work being done on that. I haven't seen anything that kind of helps us clinically in sort of a prospective fashion at this point. But I think that's always improving, in terms of node positivity. We know, certain types of tumors are more and less likely to have it. But again, the problem is that until you have that thing out of there, you sometimes don't have all that information because you're dealing with small biopsies. You don't want to disrupt the architecture, but then once you've got enough tissue to get all the information you can want, you've kind of already committed. So I think our approach right now is we want something that we can kind of commit to prospectively and say, okay, we're going to go take this thing out intact and then go from there, because it gives us more of a guidance of what to do next. But I think it is an area for study and it's an area for improvement.
And I presume after you take it out, you get more prognostic information, and then you can decide whether to do a larger surgery or not.
No, absolutely, and I think that the most exciting data that I found with this is the fact that we've got proof that a proctectomy is safe after we do this, and so in my mind that really expands the role, because I know I'm not burning a bridge. I can still go do a definitive surgery if we decide we need to.
Very good, thank you.
Thanks for your question, Dr. Koss. Any other questions from the group here today? All right, last call. Any final questions coming to mind?
Well, I want to thank everybody for having me here today. If there are evaluations filled out for CME stuff, I would encourage everyone to just take a note. You know, with these talks, you know, was this too inside baseball? Was it too general? I think that that's valuable information going forward, you know, so we can know from the GI quality committee, you know, would this be valuable in the future? And if so, how do we tailor it to meet the needs of this group? So thank you very much.